Thank you so much, Dr. Hogg. Gosh, it's a little loud, sorry. So my post-op day, a little bit of feedback, sorry. My post-op day 7 Chole is in pain help. So I'm going to start out with my disclosure slide over here. Happy to take any more disclosures if anyone wants to offer me any. Uh, and I'm going to start out with something really controversial. I'm going to talk about imaging, timing, principles of repair, and dealing with an accessory right. And I don't like the critical view. Oh my God, I said this at SAGES. So my problem is this. As Dr. Sikandi said, every case said they saw the critical view, and I truly believe that they saw the critical view. These are people that are really good at what they do. I work in private practice, and my general surgeons can do a gallbladder better than anyone I know. And this is what they think. They think that this is the single structure going into the gallbladder, and then this is the problem, right? They come across the common hepatic duct as they come through here, resecting the bile duct, not transecting it, but resecting the bile duct. And it's because this area is the most inflamed, and so this plane is the easiest plane to dissect between the artery and the bile duct. So our trainees, the first thing I do is lift up the left liver and say, look at where the hepatic artery is and aim miles away from it. That's sort of how I do it. Now, again, all of my trainees say it's really different doing a gallbladder with you because you want to see the bile duct. Everyone else doesn't want to see the bile duct. But to me, this is the key issue. So, imaging-wise, when this patient shows up to see you, what I want to know, as you've heard already, is I want to know about associated vascular injury, right? Because this changes things significantly. I actually am a fan of MRI. CT is a great choice, but that is what some imaging studies the first thing we do. And I also want to know the level of the injury. So this is my typical cholangiogram. This was what was sent to me recently. Again, for the trainees, this is not an adequate cholangiogram. You're just seeing the distal duct. This is the most common view that we get when we've got a bile duct injury. So all I'm seeing is distal duct filling. Everyone's thrilled because you're seeing duodenum, but I see nothing in the liver, right? So this is, let me see if I can, I should be, okay. So let me just drag this. So this is my arterial phase of a recent scan. It's kind of not what you want to see. You see the left hepatic artery. I don't see much on the right side. I'm getting a little bit stressed. Okay. Let's go to our portal venous phase. This is making me even more stressed because look at what's going on over here. The left portal vein is out. So this is the kind of thing you don't want to see. And this is sort of the MRCP portion of something like this. That patient was actually held for 6 weeks for me before getting to me. I wish I'd kind of just seen him to begin with. But anyway, and this is the kind of MRCP image that you see where there's a missing segment of duct. I couldn't find a good MRCP, a good EOVIST image, but this is an MRI with EOVIST. And I wanted to just bring this up because this is at 30 minutes and it's very useful. This is for a cancer, but look at the bile duct. You get a free cholangiogram with EOVIST at 20 minutes. This is great because you can actually see the leak if you use an MRI with contrast at the 20-minute scan. Okay, most of us HPB-wise use this to look at a lesion that's non-hepatocyte containing delayed, but it can be useful for the biliary phase. So this is my partner's rule, and it was alluded to in the previous thing, and we looked at our last 53 patients. We look at lap versus open, vascular injury, and biloma and sepsis, so kind of very similar to the last speaker. And what we found, we tend to be very aggressive about early repair or repair at transfer because I think from a medical legal standpoint, this is really helpful. And what we found was basically score of 4 or greater than 4. So again, none of these would give you a score of 4. We found, first of all, that this was more commonly earlier detection with less of associated injuries in females, interestingly enough. And we were looking at other things, including a deprivation index, because a lot of our patients come from a service-poor areas. But what we found also was that we were more likely to do an early repair when there was no associated risk factors as opposed to late. But we tend to be pretty aggressive about early repair in our folks, in our patients. Timing does matter. We try for early repair because it's basically, if you do it open, it's an open chole from the patient standpoint, earlier return to function, etc. If it's not early, then you've got to control biloma, generally do a PTC because a biloma drain itself is not going to be enough in general, and do a delayed repair. Remember, in order to get the PTC, one trick is you can inject the biloma, it'll fill the bile duct, and then they can hit the duct, okay? So even with the non-dilated duct, you can get a drain in. When do you do an ERCP? So this was another cholangiogram. And you can get the hint that maybe something's filling here. So this was an iPhone photograph that was sent to me. And this was the MRI. So here you kind of wonder, right, maybe we can jump this. And so yes, in this case, we did this. And just to let you know, this was unfortunately an undocumented woman who had had a lap converted to open cholecystectomy with somehow an ileostomy in the right low quadrant. So I was trying everything possible to try to avoid doing a repair, and we were able to jump this. I don't think this is going to be the end of the story, unfortunately. So principles of repair, Rulem. I generally go anticolic. I generally do everything running as a single layer. I spatulate onto the left duct. I go as high as possible because remember, blood supply is coming from above and below. Everything from below is gone, so you're relying on good vascularity from above, and I go high. If an HPB surgeon says, I want to go as low as possible so that I'll have more duct to deal with for my revision, that's not what you want to hear. The first try is your best try. And this is an illustration that I just put together. So I go high. I like hepquinade as much as possible, meaning spatulating onto the left duct. That right dives intraparenchymally quickly. The left travels extraparenchymally. So I incise onto the left and try to get as much length as possible. I always demonstrate Doppler flow in the operating room. I always get cholangiograms, and I always liver biopsy both lobes. That way, 10 years down the line, somebody can come to you and say, I'm cirrhotic because of you. I'm sorry, but you had 40% steatosis at the time of repair. There was a risk factor there. This is what we have to deal with. Right duct, left duct, this is a high injury. You want to make sure you're seeing every segment of the liver. I personally do these open, as was said by the last speaker. Whatever you do, just do it with the lowest risk of stricture. I study these, if there's a PTC, I study it at day 5 and then pull, and then cap it, pull the drain. And this last word, accessory right, scary cholangiogram, right? Cystic duct, we know it's cystic duct because of the valves. Entering into the accessory posterior sectoral duct. So this was one of my partner's cases that he just sent me this cholangiogram and said, scary, hey? And I said, sure, yeah, this is really scary. This is the scary one because this is what happens routinely. And then what happens is the drain is draining, but the ERCP is called normal because you've got left and anterior right duct, and it's not recognized as a posterior right injury. So these are the people that chill with a drain for a year before they see you. And you've got either HJ or liver resection, depending on how you do it. If you're planning an HJ, I would inject the drain and put a PTC in to that accessory duct to make it as easy as possible. Thank you all so much. This is our latest edition. Thank you.